Hey everyone, I'm back again. It is Psycho Moxie, and I'm going to be talking to you today about the common comorbidity of bipolar disorder and ASPD. So I was looking this up today because I was just kind of deep diving online, as I usually do, looking for commonalities, because when they do the assessment for ASPD, one of the criteria is that you can't be in active psychosis for bipolar disorder or schizoaffective disorder or schizophrenia when they're assessing you for ASPD. And I was thinking about that, and because I do have bipolar disorder and schizoaffective disorder, hence the 5 million pills. Hold on a second, let me just show this to you real quick. I'm in my dad's study, well, sort of study room here, if you can see that. I hope that took. If not, I'll have to cut that out and reshoot that. But that's my arsenal of medications for my bipolar disorder and schizoaffective disorder, because I am a responsible mental patient. Because anyway, the schizoaffective disorder and bipolar in particular has a lot of crossover symptoms, as a matter of fact. And I was thinking about doing some studying on that, because I just was at the psychiatrist, and I was, it's been on the fence as to whether or not I've got bipolar disorder, because I don't have the huge highs and lows of mood lability, but I do have bipolar 1, which means hypomania, which can manifest as like just the irritability and the anger manifesting, and then also like things like insomnia, things of that nature, which I do have quite a bit of that going on, which is why I take the medications I do. And which is why I'm so careful about my mental hygiene, because otherwise because it takes care of the symptoms of both ASPD and my bipolar disorder and this schizoaffective disorder as well. It's actually schizoaffective bipolar type 1 is the official term, because they're very connected. They're the same, same thing. So because the symptoms are so alike, when I take the medication for one, it's treating the other, which is one of the reasons I am in such good shape right now. So my eyes are wandering between the actual camera lens and looking at myself, because I feel like I'm talking to a person if I look at myself. So my eyes are like wandering, that's why. So I did a little deep diving into looking into what the comorbidities are and how common it is. And I ran across a study, an abstract, basically it's a cited abstract, on one of my favorite sites, which is ncbi.nlm.nih.gov. And I'll leave the link to that below if I remember, because I'm really bad at that sort of thing. But I will try to remember. And I'm going to read to you just the introduction of the study so you can get kind of a basic idea, and then I'll talk a little bit about this. So bipolar disorder, or BD, is a chronic affective disorder characterized by mood fluctuations with recurrent cycles of mania in BD1 or hypomania in BD2. I'm sorry, I've got BD2, not BD1. BD1 is a bit more severe. They have like more the really highs and the real lows, the huge mood labilities, and I don't have that. I've got BD2. I'm sorry, I get them mixed up all the time. It's hard to, because squirrel. And depressive episodes with highly variable course among patients. The lifetime prevalence of BD is estimated to be around 2 to 3% in the general population, and the subthreshold forms affect at least a further 2%. BD is characterized by a worsening in quality of life and functional impairment, and is frequently associated with other psychiatric comorbidities that could lead to a worse outcome. It has been estimated that patients with BD are exposed to a second psychiatric disorder with longitudinal rates that can be higher than 50% and may even reach 70%. So if we have bipolar disorder, we're going to be almost 70% chance that we're going to have another disorder. And chances are it could be a cluster B disorder. We'll see about that in a minute. The most common mental disorders that co-occur with BD are drug abuse, anxiety disorders, alcohol abuse, and obsessive compulsive disorder, eating disorders, attention deficit hyperactivity disorder, and post-traumatic stress disorder. In addition, particularly high is the incidence of cluster B personality disorders in BD. They're estimated at 41.2%, even in the euthemic phase, and represent a poor prognostic factor. The study of this comorbidity represents an important clinical and diagnostical challenge in psychiatry. 41.2% of us who have bipolar disorder also have a cluster B personality disorder. Let's think about that for a second now. That is an extraordinarily high rate. And I've noticed that in my groups, a lot of us have bipolar disorder. It's a huge, astounding rate of people. Hi, kitty cat. Yeah, please don't bite me because I'm not paying attention to you. Here, Esmeralda's back again. She's just a big part of my videos now. She just wants all the attention all the time. Okay, little girl, I love you. Yes, I do. So that's a huge, huge percentage of people. The study of this comorbidity represents an important clinical and diagnostic challenge in psychiatry. Furthermore, cluster B personality disorders have several common features with BD, such as impulsivity, aggressive behavior, mood instability, enough to induce some authors to consider them part of the bipolar spectrum. Instead, features associated with cluster B personality disorders may be a dimensional aspect of BD, and when combined could result in greater complexity and severity of the disease. Conversely, the presence of BD could worsen the course of a personality disorder. So if you think about that, one kind of feeds off the other, which is fabulous. One of them worsens the other one. But one thing they forgot to add here is that, probably what they mean is untreated, because these are both conditions that tend to worsen over time unless a person is extremely self-aware. It also depends on the severity of the illness, because there are, again, all these exist in the spectrum. Depends on if a person is medicated or not. Hi, kitty. And, I'm very, very careful to stay in touch with my psychiatrist. I go once a month. I'm in touch with my social worker / counselor every week. Are you sneezy? Oh dear, sweetheart. I take my medications daily, and as you saw this, I take, I think 7 pills in the morning, and then I take 1 in the afternoon, and then I take 3 in the evening. I am, very, very vigilant about my medications, so I stay as sane as I possibly can, as, my mood stays as, even as it possibly can, and this is something that they're not mentioning here, but, it's probably just, hopefully it's a given. It should be obvious that, because people who are untreated with bipolar disease, I don't know if you've ever known anybody personally with untreated bipolar, it is rough. It is rough for the person, it's rough to be around. And unfortunately, a lot of people with these illnesses are not med compliant. And I think that's just part of the illness itself. It seems to be, part of the illness is to be, really resistant to medication, unfortunately. Yes, kitty, I see you. Fortunately, that is not me. I am not like that. Do not bite me, missy. I'm gonna put this down so I can pick her up for a minute here. Come here, little girl. I know you need some attention. You need some attention and love. Say hello to everybody. I think this is part of the psychosis that can go along with it, is people don't want to be compliant. They're convinced that the meds are going to make them worse, or it's going to kill their creativity, and people with cluster Bs as well, because medication can very much help us too, even if they don't have a comorbidity. Hi, sweetheart. Yes, I know. You are just a pretty little girl. Can I talk to my people here? Can I talk to the people on YouTube? Will you let me? Thank you, sweetie. Yeah, you can have my computer for right now. And that, of course, makes it, oh shit, sweetheart, makes it so much worse. And then people are not going to get better. And that's when the disease becomes degenerative. Our brain, literally, we're going to talk about it in a minute there, but it affects the limbic system. There is actually, our limbic systems in our brain are different than everybody else's, and it can degenerate if we're not careful. Our gray matter is a bit different too. We're just actually born differently than other people, and there's evidence that people with psychopathy have got the same thing going on. And so if people were to look at my brain, they would see that there is a difference there, which is why they're saying that people with bipolar disorder and people with ASPD have similar looking brains. It affects the limbic system, but so does abuse. Childhood abuse affects the limbic system as well. So, the whole thing of nature versus nurture, kind of gets caught up in the shuffle because it could be either one, but it's generally common thought right now is that, it's cluster B personalities are made, not born, but bipolar is certainly genetic. We know that at this point. You don't become genetic through abuse. You become you get cluster B personality disorders through abuse. Please stop doing that, little girl. Yes, I love you very much. Please stop that. So let me continue on here if I can. If this girl lets me. Okay, you're gonna pout over there? That's nice. Okay, several studies have shown that the presence of cluster B personality in bipolar disorder is associated with a higher number of episodes, substance abuse, illegal behavior, a higher rate of suicide risk, even higher, great, and a poor treatment adherence. In other words, med compliance and seeing psychiatrists and seeing your it's getting noisy out there again, guys, sorry. In this scenario, researchers have focused on the impact of personality disorder on bipolar disorder, investigating the common traits that mutually lead to a worse outcome. Particularly, the clinical overlap has been shown between antisocial personality disorder and bipolar disorder. According to the DSM-5, the ASPD is described as the existence of constant and pervasive disposition to disregard and disrupt the rights of others. Other specific features include frequent violations of the law, mistreatment of others, deceitfulness, impulsivity, hostility, reckless disregard for the safety of self and others, and imprudent behaviors with lack of guilt, remorse, and empathy. All these things have been true for me at one point or another. I think I did mention I didn't, indulge in illegal activities when I was younger. This has not been true for many, many years. The rest of those things have all certainly been true of me at one point or another in my life. So, anyway, in fact, the prevalence of ASPD can be up to 5 times higher and appears to be more frequently identified in bipolar disorder 1 than bipolar disorder 2, although I do have 2. It's just because it's more frequent doesn't mean it doesn't exist in bipolar 2, clearly. And ASPD and bipolar disorder are both characterized by impulsive behaviors, substance abuse disorder that frequently lead to trouble with the law, and suicidal behavior. Studies suggested that impulsivity and the frequent use of drugs, especially alcohol, cannabis, and amphetamines, is associated with a sensation seeking and a lack of premeditation in ASPD. And now when ASPD is comorbid with bipolar disorder, it is associated with significant deficits in the ability to delay reward and greater gray matter volume in the mesolimbic reward system. So we were talking about our brains just are different. There's this sensation seeking. There's my boredom threshold is very, very low, and the sensation seeking is very high. And I did have trouble with actually 2 of those drugs, although I can't do marijuana, it makes me psychotic. So, but I was involved with alcohol for some time, and also with amphetamines when I was very young. So there's that. Now let's see, where was I? Okay. There's an attempt to detect frequency of ASPD in bipolar patients with greater accuracy and to better clarify the relationship between ASPD and BD. We conducted a systematic review of the existing literature on the frequency of ASPD and BD1, BD2, cyclothymia, and according to the DSM or ICD diagnostic criteria, evaluating the impact on clinical characteristics and outcomes. So that's as far as I'm going to read. Everything else is super, super clinical and impossible to understand. So unless you've been studying psychiatry for a while. And where did my drink go? There it is. My cat's got it right by her. So super interesting stuff because especially since she moved my camera, you little stinker. Especially since there's so many crossing, overlapping symptoms involved in the two. And then the fact that the frequency of comorbidity between the two disorders, ASPD and bipolar disorder, are so frequent, 42.1%. I mean, that's quite a bit. So you got to wonder, are we more prone as children when the abuse is occurring? Is that why it happens? So the genetic proponent is already there. My mother was bipolar as well as narcissistic. There's other family members that had bipolar disease as well. So is that why we developed the cluster B personality disorder of ASPD as opposed to a different one? That's an interesting question. So I'm hoping that they do more research on the subject. I was like looking online, and there's a few research papers, but a lot of them are like pay-per-view, which is super annoying, and I'm not going to do that. But there's enough online to like have a little bit of information, but there needs to be a lot more research done. But certainly some of the symptoms I can say are similar are the prone to irritability when I'm having an episode, when I'm having a hypomanic episode, and anger, like flashes of, intense anger sometimes. The lack of regard for safety, thrill seeking, those are all things that cross over in terms of symptomatic behavior. So it's pretty interesting if you think about it. These things are just really, really fascinating to me because it's almost like in some ways they're like the same illness. And so that's why it's especially important to take medication to control these things, because, it's like I've got ASPD squared or bipolar squared, because I've got both of these things going on. And it's, and the fact that it says it's just so much worse than people who've got the comorbidity, that's a frightening thought too, because I'm trying so hard to, not have these things control my life and to be, a lot more pro-social and a lot less irresponsible for my behaviors and for the way I interact with the world and other people and all that sort of thing. And my own, like I said before, the suicide rate for people with both illnesses is very, very high. And I know that for sure because I've been hospitalized for suicidal ideation before, especially after my son died. That was, it happened several times. So that's something I want to get ahead of, certainly, if so it doesn't happen again. Hence taking all those meds. And there's a lot of them there. Some of them are PRN, which means you take as needed, so which is why there's so many bottles. Some of them I take just for if I'm having insomnia or if I have like an acute psychotic episode with a hypomania, something like that, But as you can tell, I don't come off as somebody who's psychotic or sociopathic or psychopathic right now because I am in control of my medications and my therapies and my psychiatrist I see on a regular basis. So it's because I'm on top of shit is what it is. I get the therapy that I need. I get what I need in order to stay as stable as I possibly can. But so that I thought was a really interesting article. There's also correlations between schizoaffective disorder and ASPD, but it was really a lot harder to find articles on that. Schizophrenia and violent behavior in incarcerated men and ASPD, there's a lot more information on that, but schizoaffective disorder and schizophrenia are different enough where there wasn't enough information on that, because schizophrenia is a lot more it's more intense in terms of like the psychosis that people experience, at least from what I could read. And schizoaffective bipolar type is, it's more bipolar-y than it is schizophrenic-y, if that makes any sense. So it wasn't as easy to find information, but the bipolar stuff was, there's information on that. And then on schizophrenia, there's quite a bit because those are the violent offenders. Those tend to be the violent offenders are the ones who have both schizophrenia and ASPD, which is where you get like the Jeffrey Dahmers and people like that because they lose touch with reality entirely. And so there's a lot of studies done on that because those are the ones who have the violent criminal behavior, which is interesting because it's like, we're not the ones you should be looking at. Those of us who are just kind of, going along with, the bipolars tend not to be quite as violent, although there can be violence, certainly, and it's usually with the men, not the women. So yeah, interesting stuff, I thought, anyway. But I'm going to stop this video now because I think I've kind of got the information out there that I wanted to. But yeah, it's definitely something I didn't realize before I was doing my research on like what the differences are. But I remember just reading, like, because the DSM says you can't be in active psychosis or having an episode of bipolar illness when you're being assessed for ASPD. And that kind of was in the back of my head, and I was like, oh, that's interesting. But then when I was just sitting around today looking for something to study, that came to the forefront of my mind, and I was like, I need to look more into that, because why is that? You know, why are they that similar? And then I did that little research, found that research paper, and I was like, oh, they really are very, very similar conditions. And now I know that they can be co-morbid so frequently, which is something I just never really knew. So yeah, needs to be a lot more study put into that, because, you know, is that why it occurs so frequently? Is because it just one triggers the other? Is that why we get the illness? Because of our, you know, one triggers it when we are abused as children, you know, it triggers the cluster B when we're bipolar already. Just interesting stuff. So anyway, food for thought, interesting stuff. So like, I know there's some psychology students and psychologists out there who are looking at these videos on occasion. So if you have any information on this stuff that I don't have, you might have access to like abstracts that I don't have. So if it's interesting to you, you might look it up. And if you find anything out, please comment below and let me know what you discover, because I'd be really interested to know if there's any further stuff that I'm not able to get access to. So let me know in the comments, and I will talk to you guys later. Thanks, bye.